My name is Dr. Alexander Lyon. I'm a consultant cardiologist and I have a specialist interest in this new and emerging field of cardio-oncology. This is specializing in optimizing the cardiac health of cancer patients before, during and after their cancer treatment. And this is becoming increasingly important. First of all, many of the risk factors for cancer are shared by cardiac disease: smoking, obesity, diabetes. So many patients at the time they're diagnosed with cancer also have heart disease. In cardiology, many patients are surviving their heart attacks with modern cardiology care to live longer and develop cancer at older age. So at the time they're arriving at the oncology unit or the hematology unit, they've already had cardiac disease, and this contributes to their potential risks. So we're focusing at the beginning, at the diagnosis, to analyze their cardiovascular health, and then as they proceed through their treatment, and particularly some of the more modern treatments which we know can cause heart problems, we want to ensure that happens safely. And then finally, of course, there's the success of cancer. Many patients are being cured or having their cancer controlled so that they're living normal lives at home with medication or treatments that are keeping the cancer controlled or cured. And now heart problems are emerging in the survivors, and our job is to try and prevent that, but also to monitor and ensure the survivors are healthy, and where needed to address common risk factors such as cholesterol, diabetes, encouraging exercise. So depending on the position in the patient journey during their cancer treatment and afterwards, support from cardiology is important. And the real key factor is we understand how important these treatments are. So we're not trying to stop the cardiotoxic treatments, we're trying to support them so the cancer patients can have their best treatment safely. What we're seeing now is more and more patients during and after their cancer treatments presenting to cardiology services or emergency services with heart problems. We've known for many years that some of the old-fashioned chemotherapies, such as doxorubicin, which is used in lymphoma patients and sarcoma patients, and also epirubicin, used in breast cancer, can cause heart problems, both during treatment and sometimes many years later. We've also known that radiotherapy to the heart, if it's as part of lymphoma treatment or left breast cancer treatment, if the heart's involved, that can lead to long-term heart problems. So those things have been known for a long time. What's really exploded is all the new modern targeted or designer cancer treatments that are now having a big impact on cancers. So people are living longer, but they are cross-reacting with the heart or the blood vessels and causing cardiac disease. And when we look at the biology of how they're working on the cancer, we can understand as cardiologists why they're causing heart problems, because some of the same molecules, the targets in the cancer, are performing important healthy roles in our hearts. And so as they get blocked, it's good to block them in the cancer, but it leads to trouble in the heart. And now what we can do is monitor people, watch them carefully during their treatments with these special cancer treatments, and if the heart remains well, that's great. But if there's early signals that the heart is under strain, either on blood tests, on electrical heart tracings, or on ultrasounds of the heart looking at the pumping function, we as cardio-oncology teams working with the oncologists and with the hematologists can then start some heart medicine. So we support the heart through the cancer treatment and ensure that it can be completed safely. So to us now, with this modern world of cancer treatments, we're seeing many different types of heart problems. Recently has been the explosion of these immune therapies, so-called checkpoint inhibitors and other immune therapies. Initially, I didn't think there would be a heart problem, but actually we're now seeing some reactions, some cross-reactions whereby the body's immune system's activated, and in some people it can cause heart problems, either pumping problems because of inflammation of the heart muscle called myocarditis, or problems of the electrical system which can lead to collapsing, fainting and needing an emergency pacemaker. And our hearts all have a membrane around the heart called the pericardium, and actually these immune therapies are causing pericarditis, and that can cause a nasty sharp chest pain. So again, if we know these things are happening, we can be aware of them. So a lot is about educating our patients to be aware that if they're dizzy or getting breathless or start getting chest pains whilst taking these immunotherapy treatments, they should be seen by a specialist and have an assessment. And then, of course, in the MDT environment, in discussion with the oncologists and other colleagues, we can make a balanced judgment about how we treat the problem and is it safe to restart the checkpoint inhibitor therapy? Because again, our mission is to support the best cancer treatment. So we have several different strategies to support people who have heart problems before they start their treatment to ensure that they have their treatment safely. And this again involves an MDT discussion with our oncology colleagues to decide what's the best treatment for the cancer. That's the priority. Are there different options, some that are less heart toxic for an individual maybe who's already got a diagnosis of a cardiomyopathy or heart valve disease or a heart attack before they start their treatment? Then we can monitor people closely if they're on a treatment which we know has the potential for cardiac problems. And that's this careful monitoring, and the intensity of that and how frequently we do it and with what partly depends on the patient and what their pre-existing heart problems are, and partly on the treatment itself and what we understand that the problems are. So some people only need very occasional monitoring. Other higher risk patients need closer monitoring. So it's a personalized approach to the patient. My radiotherapy colleagues have now learned new techniques to reduce the dose that the heart may be receiving, particularly for breast cancer patients. So techniques such as deep breath holding, for example, pulls the heart down and away from the left breast whilst the radiotherapy is being delivered. So we have a number of different ways to adapt the treatment to the patient themselves. And it's all about personalising the care and then watching closely and trying to prevent things rather than rescue and responding to crises. Our vision is to try and prevent those by close monitoring and ensuring that the cancer treatment is delivered safely. So cardio-oncology has grown out of this explosion of new treatments, and it's complicated, and we need support from lots of different elements of modern healthcare teams to deliver the best care. There's cardiologists, key communication with oncologists and the hematologists about their patients, so we can discuss the benefits of the treatment and the risks of the treatment and find the correct balance for a patient. We need nursing support from specialist nurses who understand heart disease but also understand cancer. We have physiotherapy and the role of exercise training, which is critical. In cardiology, a lot of information can be acquired using modern scanning. That can be echocardiography, which is an ultrasound, also MRI, and in selected cases, cardiac PET-CT. So we bring in our imaging colleagues to an MDT environment. Some patients, if they're having serious heart problems and serious cancer problems, need palliative care support and symptom control. So we have a complex and growing MDT environment so we can have the specialist input from everyone to deliver the best care.